All right, now we're going to do the celiac disease. What is that? Typical symptoms are weight loss, chronic diarrhea, abdominal distension, growth retardation. Okay, important. Now, these are the typical, atypical dermatitis herpetiformis, iron deficiency anemia, and osteoporosis. Guys, yes, we have to know all these things. All right, next is there's abnormal serological testing, abnormal small bowel biopsy, and clinical improvement on gluten-free diet. So, what is this disease? Yes, we know it. Yes, we have to know the names. It is called spur, celiac spur, gluten enteropathy. What happens? It is a permanent dietary disorder caused by an immunologic response to gluten. A, a storage protein found in certain grains that results in diffuse damage to the proximal small intestine with malabsorption of the nutrients. Beautiful definition, guys. For inshallah clinical, you have to just learn that. So they said it can manifest between 6 months and 24 months of the age of the baby when weaning has been started to the baby. Okay, and adulthood can happen in the adulthood as well. So screening with serological test should be done. Okay, so it is associated with HLA-DQ20, DQ2 in 95% of the patients and DQ8 in 5%. All right. Now, next is clinical features, how this disease presents. GI symptoms are patient has small bowel involvement and it depends on the age of the patient. So, what are the classical? Patient has malabsorption, failure to thrive, diarrhea, steatoria, weight loss, abdominal distension, weakness, muscle wasting, growth retardation, etc. in the infants who are younger than 2 years of age. Now, a bit older, like toddlers and in the older adults, less likely to manifest the serious malabsorption type of feature, and they report chronic diarrhea, dyspepsia, flatulence due to colonic bacteria. Okay, all right. Now, this is many adults have minimal or no gastrointestinal symptoms. Okay, they don't have, or they have the atypical like fatigue, depression, iron deficiency, and osteoporosis. So, guys, sometimes the question comes and the patient, celiac disease. Sometimes it becomes very much nasty to pick up the celiac disease. Now the patient is coming and the patient is like 15 or 17 years of boy and he's presenting with the fatigue and he's so much depressed, and we see on the labs they don't say that he has iron, but we see the labs, we see the microcytosis, hemochromasia, and patient has like pain and weakness, etc. So this is atypical feature of the celiac disease. Patient can have short stature, yes, this is delayed puberty and amenorrhea and reduced fertility. These are all the features of celiac disease. This is approximately 40% of the patient with positive serology consistent with the disease have no symptoms of the disease. Okay, the natural history of the disease is silent and is unclear. Okay, sometimes it happens also. So on physical finding, what we have to see? We have to see the normal reminder case, reveal a sign of malabsorption, loss of muscle mass, upcut fat, pallor due to anemia, bruises due to vitamin K deficiency, hyperkeratosis like itching and dryness of the body due to A deficiency, bone pain, osteomalacia, and neurological like neuropathy, ataxia patient has, vitamin B12 E deficiency. Okay, we read the table and it will be so much clear for that. And patient has distended and hyperactive bowel sound. This is very much important. Dermatitis, it's a hallmark of the celiac disease. And this picture comes, we have to just pick up. And what is that picture? They say that patient has a characteristic skin rash consisting of pruritic papulovesicles over the extensor surface of the extremities and over the trunk, scalp, and neck. So extensor, not the flexor surface, right? This condition is less than 10% of the patient with celiac, and almost all patients who present dermatitis herpeti should we have to just do the intestinal mucosal biopsy because it has so much chances of having celiac. Now labs are very much important and so much troublesome. They like irritate the student. Depending on the severity of the illness, the extent of the intestinal involvement, non-specific lab abnormalities can also be seen. So this is a table, guys. We have to read first. Just let me see the table. Yes, where is that? And the page is yes. This come to here on the left page. Table 15-11, clinical manifestation of the laboratory finding in the malabsorption of the various nutrients. Different kind of First of all, and where is the disease? Where is the disease? Okay, yes, basically it all the malabsorption it presents like that. This is very beautiful like box table for the celiac disease. We can take patient has steatorrhea. Yes, we know, bulky light colored stool. And number two, patient has diarrhea, increased fecal water. Number three, patient has weight loss, muscle wasting. Four, microcytosis, macrocytosis. And patient can has, this is dual anemia and celiac disease mostly. We are just hitting that. And then patient has paresthesia, tetany, positary, Trossier sign, and Chorbic sign. Okay, due to hypocalcemia. The patient has bone pain, pathological fractures, scattered deformities, bleeding tendencies, ecchymosis, epistaxis, edema, and milk intolerance. This is, guys, important. Lactose intolerance, lactase intolerance. Right? So now, lab, what we have to do for the steatoria, we see increase fecal fat, okay, decrease serum cholesterol. Two things: decrease serum carotene, vitamin D, and vitamin A. So due to the steatoria, due to the vitamin fat containing vitamins, so they are absent. Now, malabsorbed nutrients. What will be those? No need of knowing this. Yes, we know ADEK, TGs, phospholipid cholesterol. Just leave it. Diarrhea, increase water and labs, increase stool volume definitely, and weight. It will be increase. Increase fecal fat definitely. Increase stool osmolality gap. Guys, this we have to know. Secretory diarrhea, I guess. So patient can have increased osmotic gap. Okay, I'm not sure. So, but this is a diarrhea and basically increased osmotic gap here. Weight loss, and patient has malabsorption of both fats and carbs, right? Now, weight loss and muscle wasting, increase fecal, always it's coming, increase fecal fat and decrease carbohydrate desilose absorption. This is how it is, and there is all the three nutrients: microcytic, low serum iron, iron deficiency, microcytosis, decreased vitamin B12 or red cell folate. Both B and folate both are absent. So deficiency of this. Now paresthesia, why it's that? Because of deficiency of calcium, not only calcium but magnesium, because they need both for their function. So deficiency of vitamin D, magnesium, and calcium. And next, patient has a bleeding tendency due to the K deficiency, basically prolonged PTN or INR. Patient has edema. Why? Due to the serum total protein reduction and albumin, increased fecal loss of alpha 1 antitrypsin. So basically, fats are getting lost from the body and coming more in the fever, in the stool. And protein loss as well, milk intolerance due to the abnormal lactose tolerance test and lactose. So basically, this is beautiful. It's written all here, so no need of lab. Now, serological testing. All patient has suspicion of the disease. First, we have to do is that is IgA tissue transglutaminase, that is IgTTG. Okay, this is about 98% of the sensitivity and 98% of the specificity for the disease. So this is beautiful test. Now, other test is anti-gliadin antibody. Now, this is not recommended because of their lower sensitivity. Okay, guys, anti-gliadin, don't worry about it. It's not, it is celiac disease, but it's not specific and sensitive. But yes, anti-TTG is, yes, definitely it is very much good. Another test is IgA anti-anomizal antibodies. No, okay, the same thing. So anti-glide, yes, all right. So another thing is, this always confuses us. Anti-glidin, anti-endomycin antibodies no longer used due to lack of standardization among laboratories. So guys, please note it. Then close your eyes and just say IgA and TTG. It is important and it is specific. Anti-endomycin and glidin is not. As they say, now IgA level is so much important in celiac disease. It should be obtained with, if the patient has negative IgA TTG antibodies when celiac disease is strongly suspected, because up to 3% of the patient with celiac disease have, okay, so patient have IgA deficiency, it's question Sanjay Sharma. So it was without IgA presence. So it is also present with that. Okay, so they're saying basically 3% of patient has deficiency of it. So now what we have to do when IG deficient patients, we have to match IgG antibodies to tissue transglutaminase. Guys, this is so much important. Okay, IgG TTG, we have to document like this, or to deaminated gliadin peptide, that is anti-DGP. See, that is so much important. deaminated diglidine peptides. Okay, it is an excellent. It has excellent sensitivity and specificity. Level of all the antibodies become undetectable after 3 to 24 months of the dietary. Yes, it's quickly. Yes, it's a good. Response is very good when we reduce the taking of all the food. Biopsy. Now they also know they say what is the portion from which we have to do the biopsy. So they say the proximal duodenum, bulb distal duodenum is the standard method for the confirmation of the diagnosis, the positive serological, like positives of first celiac disease. Biopsy should be persuaded if the negative serology is also present and we suspect it is a strong disease. So what we see atrophy, scalloping of the duodenal fold, and histology, we see intraepithelial lymphocytes and or extensive infiltration of the lamina propria with the lymphocytes, plasma cells, hypertrophy of the intestinal crypts, and blunting of the or complete loss of the intestinal like intestinal villus atrophy we see, and infiltration of the lymphocytes over there. So, all right. So they say partial or complete reversion of these abnormalities occur about like 2 years. We just take the 2 years, it is resolved. Well, there are lots of differentials. I quickly skim it. All the causes of malabsorption, guys. All the causes, like we have typical spur, bacterial overgrowth, cow milk intolerance, viral gastroenteritis, eosinophilic gastroenteritis, mucosal damage due to the hypertension, acid hypersecretion, and gastrinoma. These are all the differential, and we have to know the differential points of that. There is this saying that there is a thing which is called as gluten-free offer from the restaurant and food industries. This is for food map. This is basically we give restricted diet and versus. Okay, this is basically food we have to give that. Just leave it. Okay, now treatment. Remove all the gluten from the diet. Okay, barley, rye, wheat, etc. Now, next they say that what we have to do is medications. What kind of medications we have to do for these patients, and where is that? Basically, we have to basically symptomatic treatment and avoid all the we have like the things which can cause lactose intolerance, like dairy products. We have to stop that, and they have this. Yes, we have to give the what we have to give vitamin, all the vitamins, all the series, folic, zinc, iron, calcium, vitamin A, B to 6, 12, D, E, etc. We have to give that as an initial therapy to these patients. And okay, if osteoporosis is documented, we have to give vitamin D, calcium along with bisphosphonate. Okay, so evidence the patient is quickly get fine with this, and sometimes we need the TPN to these patients, and we need the oral corticosteroids if the patient has severe diarrhea and dehydration, electrolyte imbalance. We give the high tech treatment to that. Prognosis and complication of this. Prognosis is basically good. Yes, patient is association or celiac disease is associated with lots of autoimmune diseases. For example, here Addison's, yes, Graves, type 1 diabetes, myasthenia gravis, scleroderma, Sjogren syndrome, atrophic gastritis, pancreatic insufficiency. Guys, we have to cram these things because the question comes along with that. The patient has like features of Addison's disease, quickly see malabsorption. Patient's Graves disease, we see features of malabsorption. Type 1 diabetes plus features of this malabsorption, right? And MG also in that all has the question have come here. So when patients are refractory to the gluten-free diet, the most common cause is intentional or unintentional. Yes, this is also a question. If the patient is not getting fine in the 2 years, or like quickly symptomatic relief happens, guys, quickly. So we have to suspect or think that patient is not compliant to its dietary modification. This is the answer for the questions. And they say that refractory to gluten withdrawal, just leave it. Yes, guys, congratulations, we did it as well. Good.